Many hospitals, organizations use it. They modify it and make it suitable for their own organization. Don mentioned yesterday the area on the curve is about zero point 0.6 something. You know, zero point 0.5 will be a coin toss. You know, zero point 0.7, 0.65 is sort of what the LACE performance is. And we build a technology. We built a project with Amir's help and also our collaborator from TechSpring. And yesterday you saw some of the videos. So they were working with us to build out a model. And so machine learning, there's a couple of models. I always mix them up, inventing new models that never existed. But I'm not gonna say much there. And Amir is gonna explain what are the models that we evaluated. But in terms of the model itself for LACE, usually anything above 10 is considered high. In many of the analysis, retrospective analysis, found out that if you have a LACE score of 10, the chances of a readmission is probably around 20%, and 20 to 25 based on different conditions. So usually that's the readmission rate that we observe. So we think 10 is a very good, important number to look at. Now, some of the EMRs, they would say, okay, if I can have visual cues to indicate that below 10 is green, above 10 is yellow, above 13 is red, and so this will be a very good visual cue to provide to the organization. You'll see examples how organizations are doing that in their EMR. And of course, we also, Amir also built out a patient list demonstration module to show that we can also show this as well from the LACE score point of view. Another very important thing is to recognize what can you do with it. So this is an example, a hospital. I should have put in the source because this is not my invention. It's actually one of the hospitals that they developed the program using the LACE score, identify patients that are high or highest, above 10 or 13, and to incorporate patient education and also discharge medication reconciliation. And in addition is have the follow-up visits. 15 years ago when I did project at Partners, for readmission, it was simple. Get those patients follow-up visit within 7 days. Very simple, straightforward, and you can reduce lots of unplanned readmission. So these are the activities that organization will do based on the LACE score. So as Don mentioned, that you have limited resources. So can you do all the patient educations, discharge reconciliations, and also schedule all the follow-ups? And so can you actually do that for every patient? You probably don't. So you want to have a mechanism to say you focus on intervention for the top 25%, but you need some numbers to go by. But this is the actual intervention that organization will do. And for the inpatient EMR, this is an example where the daily calculation of the LACE score, and of course you can see for the patient that has very high, lots of comorbidities, and also lots of I would say length of stay is really long. They seems to have much higher score. This is where the red comes in. And so there's just an example about how you can look at daily census to calculate the risk. And then we can use the same approach to calculate our readmission risk score as well and embed it into the workflow. And so from clinical workflow point of view, there are definitely opportunities you can do this both in the inpatient side, looking at the census, or if you're at the primary care clinic, you're looking at a patient that were recently discharged from your panel, and you can rank them, you can look at them, and also accordingly as well. So both inpatient and outpatient, or you have a care management team that you want to focus on all the patients that were discharged from your network, you can also do that as well. So it becomes a very useful score in many of the clinical settings. So now I'll switch gear and jump into the technology, and I'm sure that's why you guys are here. So Amir is going to go through that.
Well, thank you, Chi. This context is very important. How many of you here are physicians? Right. Data scientists? One. Engineers? Right. You see, this is a subject that puts everything together. And as we started building this demo and investigating this subject, I learned a lot. And that's what I want to share with you, what I learned. So we want to show you how we can apply machine learning to this problem. And machine learning to any problem in general. What is the pipeline? Getting the data, all this data wrangling that you have been hearing about. How do you organize it and prepare it for creating a model, and then how you put the model into production. And the problem with readmission is very interesting because we have a good benchmark. We have LACE, as Dr. Chi mentioned. It's a very good model that is not machine learning, but predicts readmissions very well. So the question is, can we do better? Can machine learning be better than LACE at predicting readmissions? And there are papers about this out there, and we read some of them. This is just one example here. And the papers say it is possible, depending on the data you have, the quality of the data you have, the number of features. There are machine learning models that predict much better than LACE. So we wanted to try this ourselves. We took this data from TechSpring that is being collected by many different sources, and we created a model. But first, let's talk about this pipeline, how this starts, before going back to readmission, before going back to all this. Machine learning starts with data. Okay, so many data sources. We have information from primary care about, for instance, in the subject of readmissions, if you're a smoker, if you're an alcoholic, if you have some social factors that will be, your family history, that will have a weight on the score. Your lab results, right? Radiology information. The more the better, information from your previous hospitalizations, the procedures you have gone through, emergency visits you had, all this coming from many different systems, right? So all these data sources needs to be aggregated, and sometimes, depending on your country, data is coming through using different formats, and guess what? IRIS is great for that, IRIS for Health. But sometimes it's not that easy, right? If you're dealing with data outside healthcare, IRIS is just enough. But in healthcare, things are a lot more complex. You often have all these very weird formats, HL7, ASTM, FHIR, all the IAG profiles, all these information exchanges, information on maybe claims, and IRIS for Health helps you. But you still have to link this data together properly, right? Who knows if this lab result belongs to this patient? It's coming from a different system. It's a big challenge, right? And you just heard about news about our master patient index that is applying machine learning to help on some aspect of this job. But you need a master patient index. And you need to store all these documents, these lab results, radiology results, discharge summaries. You need to store all of that, link them together, extract information from them, put that on a meaningful data model. So you can, and we have even started with the machine learning yet, right? And, well, HealthShare is very good at that. So I just wanted to tell you here that there are people here that is coming to this presentation because of the machine learning part of it, or because of the engineering part of it. And if you are doing something, for instance, if you are predicting anomalies, if you are predicting some malfunction on some equipment in the factory floor, IRIS is great for that. And we can work with IoT. But in healthcare, I would say think about IRIS for Health, but most importantly, the more the better, the more data you have, the better. Think about HealthShare. Don't reinvent the wheel, okay? So here we are taking a look at what HealthShare can do for you, and all these sources are stored on document repositories, and we have the MPI there linking all this data for us. And HealthShare has this plugin, this Health Insight, that will just take all this data and leave that for you on a very nice data model, on tables. Okay. So now you have on a single data lake, a normalized data lake, in real time, information that is flowing from all these systems, from all these facilities. And that is very, very valuable. That's the starting point. Okay. So that is your data lake. So it doesn't really matter how you get here, how you got here, right? If you have health share, perfect. If you did by hand with Health Insight, with IRIS for Health, because maybe you're using a system that has an MPI there and it's all solved for you, and you just need to extract data from that system and put it on a data lake. That is fine too. Okay, if you have like a system like Epic and it's running on your region and all the data is already there, great. You just need to take that data, leave it on a data model, on a normalized data lake, so you can start working with it. But if you are grabbing data from all sorts of places, you need more than that. But you got here. You have this normalized data lake. And now you have all these infinite possibilities, right? You can do descriptive analytics, showing some counts, right? Statistics, and predictive analytics. Readmission risk is just an example. But every problem needs different data. Every problem, if I'm predicting some risk, I will pay attention to some aspects of the patient than others. And we don't really know what is going to weigh thin. The model will decide, right? But every model starts with some chunk of data out of this normalized data lake. So it's a nice strategy for a region, for an insurance company, to have all this data at hand and unleash data science at it and start innovating with all these different approaches. I want to reach out to my patients to find patients that are at risk of developing some chronic diseases. I want to predict readmissions. I want to I'll do all sorts of stuff. Who knows, right? So there are infinite possibilities, but every problem needs some chunk of this data. So, and we need to extract that and aggregate it even more because we did the linking, normalization, right? We linked the lab results to the right patient, the discharge summary to the right patients. We figured out who the patients are, and we left all of that on the data model, and that is great. But now we need to do some aggregations that are specific for the problem. So I will give you an example, and that's the part like that I really learned a lot when working on this problem. Let's look at the readmission problem. So here you see a timeline of a fictitious patient, and in 1999, on primary care, someone typed in, oh, he's a smoker, all right, and he has a hypertension. And then he had a car accident, and he was hospitalized, and then he was diagnosed with diabetes, and then next year he went into surgery, did a bariatric surgery, right, and lost weight. But 8 years later, he had a heart attack, right, and entered the emergency department and went straight to hospitalization after that. I invented this, okay? So if you see something wrong here, it's my fault. I'm an engineer. I put this story together. But I think it's good enough. But you have outpatients, emergency, and inpatient visitors here. And the readmission problem is all about inpatients. You still need all the data. You still need to know all this. But you have to give a score to the hospitalizations, right? So we have to aggregate this to start training the model. So let's start aggregating 2000. That it was his hospitalization. So now, looking at the patient at the year 2000, he was there hospitalized but because of a car accident, but he was a smoker and he had hypertension. And then we keep aggregating. In 2011, we have more. Now he's still a smoker, he has hypertension, diabetes now, and he's here now for a bariatric surgery. So we keep aggregating, and then at 2019, that's the view of the patient. So the patient has diabetes, is a smoker, has hypertension. He's being admitted to inpatient, to hospitalization through emergency because of a heart attack. And that is what we need to feed to the model. So there is this specific aggregation that needs to be done for the case of readmission. All right? So, but how the machine learns, right? We just aggregated data, right? But how do teach the machine about the prediction? We were looking at the past and aggregating, right? We now need to look into the future. So on each readmission, for instance, in 2000, we have to look 30 days in the future and see, is there a readmission? Has the patient come back to, has the patient been hospitalized again in 30 days? Yes or no? And then in 2011, we ask the same question. Has the patient come back and been hospitalized again? Yes or no? Because that's the problem, right? We want to predict readmissions in 30 days. So that's another aggregation you have to do. And then you say, I can hopefully move my mouse here. No, forget it. But there is this flag that you're seeing there, will readmit equals false, and then true because you're not seeing, but he's coming back. It's right here outside of the screen. But the patient's coming back, so it's true. And with that, now we have something that the machine can use. So that's how the model looks like besides something other. We're just showing you a small sample of the STAR schema. So we have for every inpatient here, for every admission in hospitalization, we have a list of comorbidities. Maybe this patient has, I don't know, well, we can look at the table, right? 2 is diabetes, 1 is asthma. This patient here has both. You're not seeing my mouse, I'm sorry. But I'm looking at the first column, and the first row in the table at the center says the patient doesn't have any comorbidities. The second says the patient has comorbidities number 2, which means diabetes, if you look at the table in your left. And the fourth patient has 2 comorbidities. The 1 and 2, it's asthma and diabetes. So it's a list of values. Every column has a list of values. And then there is a smoker column that is a binary value, 0 or 1. You either is a smoker or not. And then the discharge destination, the patient has been sent home, has been sent to a nursing home, has the patient diseased, died, and then that column will readmit. So we have many more columns. I'm just giving you an example of how this aggregation looks like when you're preparing the data to train the model. So it's not only about fetching the data from all those data sources, linking the records together safely, putting all this data on a nice data model on a database. You have to do further aggregations like these to prepare the data to train the model. Okay. Now the machine can look at this and see, okay, so this first patient will not readmit, and those are the features. The second patient will not readmit, and that are the features. The third patient will readmit, and then the machine can build the model. And again, every problem will have a different aggregation. If you are trying to predict diabetes risk, it's a different aggregation. It's different features. You need to, put the data together in some other format. Renal chronic disease, heart attack, I don't know, whatever you're trying to predict, you manage the data, you aggregate the data differently. So different algorithms, well, we're not done yet. There is more. Depending on the algorithm you're using. Machine learning looks like this magical thing, but you have many algorithms. You have linear regression, you have all sorts of decision trees, you have neural networks, I would say, 20 and 30, I can't say, but it's a lot. Many variations of algorithms. And algorithms like their food with different condiments. What is their food? Data. And they like data prepared with different condiments. So, for instance, one-hot encoding. What is this? That table you're looking at is not really good enough for machine learning. The aggregation is done, and it's helpful, but it can't be consumed by a machine learning algorithms just yet. So, for instance, the first column, for comorbidities, it says it has this list, and it's translated into asthma, diabetes, and all the comorbidities, right? That in itself is another aggregation, right? It's for instance, diabetes may be an aggregation of all the ICD-10 codes that means diabetes, and it's in itself it's an aggregation. But for decision trees and neural networks, they don't like to see the data like this. They like one-hot encoding the data. So that column there, comorbidities, become as many columns as you have comorbidities. So if I have 20 comorbidities, I will have 20 columns that will just say this patient has this or it has not. And that's how the model likes the data. Okay, so you need to apply that. But you can't apply one-hot encoding to everything. Okay, so depending on what you're doing, you apply one-hot encoding to some of the columns and not to others. For instance, decision trees do like the comorbidities to be all, each one on their very own column, but they don't like, for instance, the discharge destination that is just like you was either sent home or to a nursing facility or you died. You have just one destination. So it's one value that may be 1, 2, 3, or 4, or 5. For decision trees, that is great. They love it. They perform better with that. Neural networks, on the other hand, don't. They really like full one-hot encoding to all the columns. So depending on the model, you have to take that aggregated data and prepare it even further to put like some salt here, some more condiments for these machine learning models. And that's where the data scientists come in. He knows that algorithm. He knows what that algorithm expects. He's the chef, and he prepares the data just for that algorithm. And we're not done yet. For instance, there are things like normalization, and you may take a column that has a range of values, like length of stay, how many days have you spent here, and apply further normalization to it. And that looks like this. So length of stay, 5, 3, 5, 4 on the left, length of stay, but normalized, it has all these fraction values you see there, and that is min-max normalization. But maybe you want mean normalization. Maybe you want, I don't know, I'm not a data scientist, I'm just telling you what they're doing. They do this, they think about that every day. Standardization, those are different techniques of normalization. And there are algorithms that like one sort of normalization better than others. So the pipeline looks like this now. So I'll have all that data on the data lake. I have a problem. I have to prepare the data for that problem, and then I have to do further preparation, put some salt, some pepper there for different algorithms because they have different tastes, and then I can feed that to the algorithms. And you can use, TensorFlow, R, Spark. You have seen on the conference. We have QuickML now that makes this a lot easier. What's the food that QuickML expects to receive? Is that orange stuff you're seeing there? It's the final product. Okay. So, and then you have a model. Okay, now I have one model. I have looked into many, and now I have one model. Right, so that's what I want to show you here very quickly with the time that I have left in the demo. So before I do that, do you have questions about this pipeline? No?
I have a question, but it's more about the methodology in terms of determining what algorithms you need for what kind of risks in terms of readmission. What guidelines, or is it just heuristic in terms of you go through the process and you find out what algorithms work best for what outcomes that kind of match what you're looking for?
The data scientist, I have been working with a data scientist, and he has some sentiment. He knows the algorithms and how they work. So they kind of know, oh, this problem is really good for neural networks, or this problem is really good for decision trees. And then they understand what are the condiments they have to add. Oh, hence I need one-hot encoding. Hence I need full one-hot encoding, and these kind of normalizations. But at the end of the day, the quality of the data also plays a very big role there. You can't possibly look at your data and be really sure that it's well, we can't run some statistical analysis and realize, oh, I have a bunch of null values here. I have a bunch of missing fields here, and the data quality is not good, but what's the impact? They have to really train the model and look, and they will compare. Okay, but they at least will not lose their time with a model they know for sure is not going to be performant. But they have a very good sentiment about this.
Can I just add on that? How would a data engineer go about this if they don't have access to data scientists? What is the best approach?
Well, QuickML is very good at that. That's the idea. QuickML, what's doing in the back end is he's not doing all of this, of the orange stuff. You still have to do that yourself. But he's running several different models, different algorithms, and trying to pick the one that has the best accuracy. So, but you still have to prepare the data. So let's look at the demo. So first of all, this demo is a composition of many containers. Okay, so I have Iris, I have a Spark cluster, I have a Zeppelin a container with a notebook. I have an all here, and all the source code is on GitHub, and it's running with Iris Community, which doesn't require a license, and it's going to be released soon. It's not public yet. It's still on a private repo, but it's going to be released soon. So it's a very good demo. That's a very good example with machine learning and Iris, with the readmission problem that is going to be open source. And here I describe this pipeline and how to run the demo. So let's go to the demo. So the demo screen looks like this. Let me just make sure I'm logged in. And I will click this button here, and it will start opening some screens that will help me to. I think I pushed the wrong button. Just a second. Okay, I'll close this and open again. Okay, so this is the one I wanted to push. Okay. So this is a simulation of a EMR, okay, and I can look for patients here. I can look at my patient census, and I can see all the patients that are admitted for that are hospitalized. And for every patient, I can see the LACE risk. Well, actually, the LACE risk for this first patient is 9, but we have used that table that Chile showed that translates a LACE score into a readmission rate, so 7.9% risk of readmission, right? So every patient here, if I click on this third patient, I can see that it has a LACE score of 3, and that translates to 3.3% risk of readmission. And why am I doing this? Why I'm putting here readmission risk as a percentage score? Because I want to compare it to the machine learning risk, right? Because machine learning gives me a percentage score. Like this is the probability of readmission. And as you can see here, the score, machine learning thinks that this patient has a much higher risk of readmission than LACE thinks. And that is real. You can download this demo, look at the data yourselves, look at the model we built. In this case, you're going to see it's a random forest. That was the best model for this problem. And you see that in this case, LACE was machine learning was much better. And that means I can, while the patient is hospitalized, I can educate the patient. I can do all these things that Chile showed you, like all these things I can do, and maybe discharge the patient instead of sending the patient home, to send the patient to a nursing home, and all these things that I can do to prevent readmission. But if I was looking only to LACE, I would let that patient go, right? $15,000 later. So here I'm spending $200, giving the patient some education, visiting the patient, sending the patient to a nursing home, I don't know. And here I'm spending $15,000 on a readmission. Okay. So, and how am I doing this? Well, as I'm doing things on the EMR, or the lab results are coming in here, we were here at the EMR, all this data is being sent to IRIS, and I'm taking all of this, extracting the data from all these messages, storing on a data lake, and here on the data lake is where I'm transforming those tables in, I'm aggregating and then preparing for machine learning. So we can look at this. I use DeepC, I use IRIS Architect to do the aggregation. So it's really easy. You know DeepC, you know IRIS Architect. You can just take the encounter table and start dragging columns in creating features and model and measures. So here I have the gender of the patient, the start date, end date. Why start date is decomposed like that? Because depending on the time of the year, the risk is higher, and it's good to know the month individually for the machine learning to look at it. Admission source, maybe you came from emergency department, and that changes the model. Discharge location, where did I send you? Maybe I sent you home, maybe I sent you to a nursing home, and it has an impact on this problem. Encounter type, age group, comorbidities. So this discharge location here is, if you see, it's a very simple property. But comorbidities is an expression. I'm doing some crazy stuff there. I'm selecting all the diagnoses that the patient has at the point of this hospitalization, not in the future, but from there to the past. I'm translating all the ICD codes into the comorbidities and giving a list back, a list of comorbidities. But all this code is very well organized in this method that I'm calling here. And you can actually look at the data. You can go to Analyzer and see, okay, I want to see, I don't know, patients that use drugs. How is the distribution? No, how is that? Let's see. Oh, no, this is a measure. So the gender distribution, right? I don't know. Comorbidities, right? And let's pivot this. So all the comorbidities, how many patients I have. So you can look at the data. You know deep C, right? But as I said, this is not good enough for machine learning. If you look at the star schema that this generates, I'm out of time, I think. My watch says 0 all the time since I started. So, but I'll try to be quick here. If I look at the model, IRIS model, IRIS demo, CubeML encounter. That's the fact table here. So you see here the comorbidities column. So those are the patients. You see that I have patients who has 2 comorbidities, right? And as I told you, this is not good enough for machine learning. And I may have here length of stay and other measurements that need normalization. So I need to do more. And we can publish this cube for specific algorithms. On this demo, this is not in IRIS, but it's on the demo. We wrote code that will just take this cube and publish it as what we call an ABT, analytical base table. This table that has many, many columns, right? By itself, it's good enough for the machine learning algorithm. So let me show you what this looks like. So here it is. This is, how can I call this? So if you look at this now, you see comorbidities, HIV, comorbidities, cerebrovascular disease, comorbidities. This is one hot encoding, okay? And if you look at some other columns here, you see that the values are normalized. So now I can give this to the data scientist. Now they can run models on top of this. So you can publish the star schema, the deep C cube, with different condiments. I want this with full one-hot encoding for neural networks because I'm not sure. Maybe neural networks will be good for my problem, maybe not. I want partial one-hot encoding for decision trees. I want this kind of normalizations. And you can publish one and over again without taking space in your disk because this is not actually copying your data. So the pipeline is I'm extracting the data, storing on tables. I build the right cube for my problem. And then I publish this cube twice, 3 times, 4 times, depending on the algorithms the data scientist is planning on using. And then the data scientist can come here with his tool of choice, like Zeppelin with Spark Cluster, and fetch the data. So here I'm using, the data scientist used Scala, and he fetched that data, and he looked at the data, the ABT, the analytical base table here, and he kept going. I will not spend your time here, but this is going to be open source. You can look that yourselves. But he tried a binary decision tree first. That's one algorithm. And then he tried a random forest, right, on the same data, and then boosted trees. And he kept going. At the end of it, he reached he compared the accuracies of all these models and say, okay, random forest is much better. And then he exported the model as PMML. And we can take that, plug it here, and just run it, and expose it as a web service for the EMR to call. So the EMR now just has to say, I have this encounter ID, I need a score for this, on a REST service call. Okay, so I'm out of time by 5 minutes. I'll stop for questions.
So I have one question. So you talked about the one-hot encoder. So you have an API in IRIS itself to do that?
Yeah, we built that for the demo. We built the one-hot encoding and some normalization algorithms for the demo. The challenge here is we didn't want to let the data scientists do all this data wrangling, because you would get a model, and then you would have to go after the data and join it, do the one-hot encoding, normalization, all over again.
And my second question was, why did you run this the decision tree and the random forest and all those? Did the QML, can we do it here itself? Again, this one.
The
QML will run all that.
the QuickML will run all the algorithms for you, but you still have to prepare the data for it. But the thing is that we did this on a traditional way, where we were using Scala and Spark with a real data scientist here, right? And the data scientist, he has his intuition, like he can tell you, go grab this type of data, bring me this and bring me that. And if you are alone, you may be lucky, right, joining all this data yourself, and okay, I will just give this all to QuickML, and you have some good enough results to get started. But eventually, you want a data scientist to go further into this, to get a much better model. And he will have all these intuitions, and he will not be using QuickML. He will be using Spark and R or Python scikit or some tool of his choice.
No, I'm saying just to get which is the best algorithm to run, the random forest, or it is the binary tree classifier, or
It depends. That depends on your problem. Depends on on the data. There are problems, for instance, that linear regression is just great.
will QML give me that or not? I mean, that's the point.
QuickML will try some basic, like the linear regression, decision trees. He'll do that for you. But it doesn't come with the intuition of a data scientist. Like, what is the data that you need to bring for this automatic model building to happen, right?